really, when I started this, let's see, going backwards, okay. When they asked me to do this lecture, I said, well, there's no way I can do it without reviewing the law. And Fitz, you gonna come up? Fitz's lecture was very closely tied into this lecture. And what happened is in July of 2018, we had the HB 21. And recently we had the, let's see, 451, I think it was one of them. We fought so many of them, I get the numbers mixed up. But anyway, it's incorporated into 456, and it was an extension of HB 21. So I'm going to go over it. And how many of you taken the mandatory course for opioid prescribing? So everyone, how many have not? Let's do that. How many have not? So nobody, one has not. Okay. So I got involved in this because there's mandatory physician education, and I'm big on educating us. It's one of the things I do a lot of. And so we have to get 2 hours of mandatory education on opioids. If you prescribe anything, really, is the way the bill reads. And Fitz, correct me if I'm wrong on any of these issues. Even, my understanding is even cough syrup. And that's a 5, right? But Lyrica and I think low modal is exempted from that. And then mandatory review of the prescription drug monitoring program, which we're going to get into, and Fitz covered. Limitations on prescribing controlled substances, mandatory emergency opioid antagonist, Board of Medicine to adopt standards about the practice and treatment of acute pain. So what they're saying is they're going to evolve this law, so we always have to keep our finger on the pulse for changes. And then review of HB 421, which is a new law that requires for non-opioid alternatives that we have to educate our patients on non-opioid alternatives whenever we prescribe a controlled substance. And we have to give them the pamphlet developed by the Department of Health. Not one that you developed, not one that anybody else has developed, but the specific pamphlet from the Department of Health developed by the Department of Health, which FSIP played a hand in. All righty, so mandatory physician education. Prior to January 31st, 2019, all physicians registered with the DEA with the ability to prescribe. So you can't not get the course because you don't prescribe. If you have a DEA license, you have to do this. And I would highly recommend that you not give up your DEA license. So just like HIV was mandatory, just like medical errors is mandatory, domestic violence, now we have opioids, which is probably a good thing in the long run. Because their whole philosophy is that doctors prescribe, they get their patients addicted, they prescribe too much for too long, and then the patient winds up in an addict, and then they throw them out of the office, and then they're on the street taking heroin. So that's their whole mantra. So we get the 2-hour base course, and if you have a DEA license, you would mandate it to get that by January 31st, 2019. And then you get it every 2 years on your relicensure cycle. So the physician will take the 2-hour course every 2 years, and the course, now this is different than every other CME we get. The course must be approved by the Board of Medicine. So far, I'm going to show you about 7 or 8 societies have went to the Board of Medicine and said, these are the slides for our 2-hour mandatory course. And the board says, okay, you can do it, or okay, you can't do it. So you have to have an approved course. You can't just go take 2 hours of CME online. It has to be an approved course, and I'll show you where you find that information on that takedown site that Fitz talked about. All right, so here was the notification that you have to have the 2-hour course by January 1/31/19. So Doc, if you don't have it and you have a DEA license, go and get it and make up some kind of excuse to why you didn't get it.
State requirements are different. We're talking about Florida. Texas doesn't have mandatory.
Oh, Texas?
Correct.
Right, okay, different state. This is Florida law, right. Okay, yeah. This is just for us Floridian doctors. But if you're here from another state just for our meeting, thank you very much. All right, so HB 21, the current standards for prescribing controlled substances are in the bill, non-pharmacological therapies, prescribing emergency opioid antagonists, like I said, I'll go over, the risk of opioid addiction following treatment, so this is all something you need to cover, and the course in the course has to be covered, and the course be offered in a distance learning format, and must be included within a number of continuing education hours, which is 2. All right, so you can get this course online with the FMA. Members pay $25, non-members $75. It's 2 hours of credit, and there's the website where you can go to get it. So if you've got it by January 31st and your relicensure is going to be this coming January, then I think you're okay. If not, you can go and get it online with the FMA. Now, so these are the associations and societies that are approved to give the course. And when we started out, we had these 1, 2, 3, 4, 5, 6, 7, and then emergency medicine learning and resource was added. Now, these little stars mean it's not approved for DOs, not available for DOs. So if you're DO, you need to get any of these here or any of these down here. And the takedown website that Fitz showed you is where it shows you who's able to give the course. Now, I've gone to 3 of the courses and I've given 2. And I can tell you that the quality of the event is very different from different providers. The first one I went to was the FMA. It was given by a lawyer. It was terrible. All she did was walk up and down the aisle and talk about her family experience with opioid addiction. She didn't talk about the 3-day, the exemption, the non-opioid, the PDMP. That's all stuff that we need to know, technical stuff that we need to know. And so it was really bad. So anyway, I hope you get a good one when you choose one. All right? So then the physician must check the prescription drug monitoring database. And they data mine if you check it or not. Now, Fitz doesn't think this is going to happen, but what I think is going to happen, once this thing gets rolling, how they're going to penalize you, because it's mandatory, is they're going to see who got a prescription, where they got it, who wrote it, and then whether you accessed it soon before you prescribed. So that's how they'll get their disciplinary action for not entering into the PDMP before you write a prescription. So now this was new. The designees were new. That's really good because, you know, when Rafael Miguel passed, he was very involved in the FSIP organization. And he was very influential in getting that designee, because who of us, even if you see 20 patients a day, if it takes you 3 minutes to get down 3 times 20, you know, you're wasting a lot of time bringing it down. So we want to make sure that the designees are able to. So what happens is you're all in it, and then your designee goes in under you, and she gets her own password to enter the PDMP. So in the morning, my girl, if I see 20 patients, she gets 20, and I'm going to write 20 prescriptions, she gets 20 PDMPs. And there's a website where you can go to the eForce website, all right? So you must access for all controlled substances 2 through 5, with the exception of Lyrica and Lomotil. If you can, you must document the reason that you're only going to write a 3-day, so, or greater than a 3-day, and you must put the PDMP in your chart. Okay, you do not put the PDMP in your chart, excuse me, because you can never, ever send out the PDMP. Not to a lawyer, not to a judge, not to a patient, not to a patient's family. You can never, ever send it out. I used to keep it in my patient's folder because I make decisions based on what's on there. But now you just have to document it in your record. It is illegal to send out the PDMP to a lawyer, to anybody. So you never want to send it out. Now, if you wanted to put it in the record and you have staff who know when you get a subpoena or a request for information from a carrier or anybody else that they cannot send it out, you can put it in if you want. I have that kind of staff, but I'm still not putting it in anymore. All right, progress notes. You must reference, so how do they know? You must reference that you checked the PDMP. So my template says PDMP checked, and I always check it. And I think the risk score on Fitz's slides was very good, because you can, if you want to wean them, you can discuss, hey, this is what your risk score is. I have 95-year-olds taking 4 10/325 oxycodones a day, and I keep saying, you know, like, I'm surprised. If I took that much, I would be on the floor. So anyway, never send it. Okay, so the law says, and the Board of Medicine has stated, that there will be penalty for not using the PDMP. And they suggested, along with their evolution of what they're going to decide, that there be financial penalty. So there's a first offense that's non-disciplinary, but with a citation. A second offense that's subject to discipline, so you could get suspended or penalized in some other way. And then the third is willful malfeasance, and that's a first-degree misdemeanor. So you have to access the PDMP when you're prescribing anything, including cough syrup. So designees, this is very good, approved staff, so they don't limit. You could have 5 of your staff approved or not. I would not have anybody approved who you don't trust, because that means if they want to figure out if their boyfriend is taking anything, they can go in and put his name in and access him, which is a HIPAA violation. So you don't want to put somebody you don't trust as a designee. Make sure you trust everyone, including your husband, if your husband, or your wife, if you feel like they're going to go in and look at, see who you're prescribing for what. Don't do that either. Okay. The penalties. So this is what they proposed. For the first, $1,000 to $2,500. For the second, $2,500 to $5,000, along with whatever disciplinary action. And for the third, $5,000 to $10,000. So not only are you going to have disciplinary action, but you're going to have a fine. All right. Okay. So now. Limitations on prescribing. So now this was mostly for surgeons, because they really feel like, you know, what happens is somebody has a surgical or traumatic experience, the doctor prescribes, and he keeps prescribing and prescribing and prescribing. So they are limiting acute pain to a 3-day supply. Now, and most of you, if you went to the mandatory meeting, hopefully you heard this. I really emphasize this when I'm giving the course. And so you're going to write a 3-day supply for post-op or post-ankle sprain. If it's not post-op, what you might see, an elbow, an ankle, a finger, a hand, something like that, 3 days. If you feel like it justifies a 7-day, you can write, instead of acute pain, you can write acute pain exemption on the prescription. And then the pharmacist will let it go. May call you up, but will let it go. And by the way the law rules is for the third one would be non-acute pain. So if you're writing more than 7 days, it's non-acute pain, even if it's surgical pain or traumatic pain. More than 7 days is non-acute pain, even though the definition of malignant pain is greater than 90 days. Anything over 7 days is non-acute pain. So a pharmacist calls me up and she says, the way the bill reads is non-acute pain is all one word. So she says, I can't take this because there's no spaces between the non, the acute, and the pain. By the way, I have to talk to you about that, Fitz. So I said, okay, I'll resend it with non-acute pain. So in my little Hernando County there, Fitz, Citrus, Hernando, Pasco, each of my pharmacies has different rules. One will take a 1-month electronic script, one will take a 3-month electronic script, and not only that, but each of the PharmDs have different rules. So one day, PharmD calls me up and she says, this patient needs an orthopedic, to get this much medication, this patient needs an orthopedic consult. I said, have you seen the medical record? No. Well, tell me why she needs a medical consult. I can't tell you. This is what my confinements are, and that's that. Okay, fine. So the patient wound up going to another pharmacy, which Sandy likes a lot there. So I'm trying to put my own experience in with this because it's amusing to me. Anyway, acute pain exemption. Non-acute pain is chronic non-malignant pain, the way we call it, or not. If it's a traumatic thing and they'll be on it for 6 weeks, then you wean them off. And then you can't write just PRN, Percocet PRN. It has to be PRN a reason. Post-op pain, trauma, pancreatitis, irritable bowel syndrome, whatever. Okay? So no PRN without a reason, or you'll get a phone call. And then this is really, really confusing, and I'm not going to go into it because I promised Andrea I was going to give you 15 minutes of my time. But I'm going to show you something about this injury severity score. All right? So if you see a patient with an injury severity score of greater than 9, and I don't know, I had to read last year, I had to read all about what an injury severity score was, because I didn't know. And I talked to doctors, they don't know. Who knows is trauma surgeons. That's who knows. So anyway, if they have an injury severity score of greater than 9, which I have taken to, if I'm suspicious that they're going to have a problem, you have to mandated prescribe a antagonist. So we got the Vizio there, and we got the Narcan. So the nasal spray Narcan, Vizio, it's $200. So, a lot of people don't want to go get it. But it doesn't matter if they don't go get it. It just matters that you prescribed it. All right. So the injury severity score, called the ISS, divides the body into several systems, and the head, neck, face, chest, abdomen. And then there's a severity point for each one. Now, more interesting than that is that the injury severity score comes from the abbreviated injury score, okay? So you go to the abbreviated injury score, and that divides the body, and then somehow you get 6 on each one here, and that gives you 75 on the injury severity score. It makes no sense whatsoever. All right, so I put these here. I don't have time for this, but I put these here for you. You can go online and look it up yourself. Have fun. All right, so we got the injury severity score, and this comes from the abbreviated injury severity. So here's the points that you wind up with when you multiply, after you multiply. All right, so the Board of Medicine is to adopt standards. That's, I said, the catch-22 in all this, keeping up with it. But if you come to our meetings, we'll always keep you up. And then the definition of acute pain means this is normal, predicted physiological pain, thermal, mechanical, surgery, trauma, acute illness. And then I put the schedules on there for you and highlighted you'll have this slide if you take down the app, or if you go to our website, you'll have this presentation. So I highlighted for you the things that we normally prescribe. And so that's like 3 or 4 pages. You can get that also. So the standards of practice are really a reiteration of the pill mill bill. And that's all of this stuff that you already do. And then the treatment plan is important, and the functional assessment is important. That, now I'm saying they've been to chiropractic, they've been to acupuncture, they've been to physical therapy, they've been to biofeedback, they've had a brace, they've had acupuncture, I said, and they've had non-steroidal anti-inflammatories, they've had numerous other opioid analgesics. I mean, I just cover everything. I have a list, and I check it when I'm interviewing the patient, so I can say that. So, and then the definition of chronic pain, progressive disease or medical or surgical condition that causes significant functional impairment. And then mandatory application. Okay, So in the, FSIP did this for you, Larry. They got you exempted from the pill mill law. The reason you don't have to register as a pill mill is because FSIP was in there every board meeting, every Department of Health meeting with a lobbyist that cost them $65,000 a year to make sure that you got exempted from registering as a pill mill, because the regulations and the documentation are in a folder about that thick. So anyway, you were exempted automatically. But now, after HB 21, you have to write to the board, tell them the reason you're exempted: I'm a fellowship trained, board certified pain medicine doctor, and then they write you back a letter, yes, you are exempted. So now you have to write them a letter to get the exemption. You're not just automatically exempted. So,
You have to show proof.
you have to keep that letter in your binder.
You have to show the Department of Health proof
Yeah.
that you're exempted.
You have to show proof of what the exemption is: board certified, fellowship trained, what the requirements are in the pill mill law to be exempted. Okay. You got that? Is that okay? All right. All right. So then HB 451. So I'm almost done. And good. I gave Andrea plenty of time. Don't leave. Her presentation is astronomical. How do I know? Because I looked, she sent it to me. Anyway, so the new law, 451, is the alternatives to opioids. So now, before you write a prescription, in your note, you have to say that you discussed with the patients the alternatives, which are the chiropractic manipulation, the physical therapy, the nonsteroidals, the membrane stabilizers, all of those things. So you have to say in your note you did them, and then you have to give them a pamphlet from the Department of Health. And it can't be, like I said, it can't be any old pamphlet. It has to be from the Department of Health. So I'm going to show you something in a minute here. So if you want the pamphlet, you're going to go right here, right? Now, if you don't see a lot of patients and you don't have a lot of prescriptions that you're writing, you can just kind of probably print it out on your printer. My practice is fairly large, 4 pain doctors, and we ordered from Sir Speedy. So we ordered 2,000 from Sir Speedy. We gave them the link to the pamphlet. They did the pamphlet for us. It's 1 page on both sides, so we folded it over. We give it to the patient, and it was 21 cents for each. And we thought that was least expensive rather than using our printer and putting those $60 cartridges in there every time. So the pamphlet is published, and here's your link to the pamphlet. That is a law. You have to give the pamphlet developed by the Department of Health. And your FSIP here was involved in that pamphlet. Otherwise, it would have been a disaster. God knows what you would have had to do. So all we say is chiropractor, physical therapy, all those things, boom, boom, boom. All the questions you ask, okay? So there's where you get your pamphlet. And that, you had to do that in July. So if you haven't been doing it, start doing it. All right, so here's a template for you. All right, you can put this in, you use electronic or hand. If you use hand notes, you can create a little sticky, manual notes. If not, you can put this right into your notes. So this does everything. Opioid analgesics have been discussed with the patient, who understands the risk, benefits, and side effects of opioid use, including tolerance and dependence. The patient agrees to sign the opioid agreement. That's in HB 21 from 2012 in the pill mill legislation. The patient agrees to sign an opioid agreement outlined and detailed if the need for prescribing opioid analgesics is considered indicated. The patient's risk assessment is considered moderate to high. I think anybody on opioids has a moderate risk assessment. I don't think anybody's low. So I say moderate to high. For pharmacological medication management secondary to the patient's chronic painful condition as diagnosed. Additionally, potential drug interactions with the patient's current medications were reviewed and discussed with the patient. The patient has been informed of the non-opioid alternatives, so that's the law there. and the advantages and disadvantages of the non-opioid alternatives. Non-opioid therapy has been considered. The patient was provided with the Florida Department of Health approved non-opioid alternative educational pamphlet. And that will be in your slide. So that I have that templated, along with the urine drug screen and a few other things. All right, so I was good, 30 minutes. Anybody have any questions about that? Yes, Miguel. You have to give it to them, and you have to document in your record that you gave it to them. Now, the third time they come, if you say, here's the pamphlet, and they say, you already gave it to me, you can take it back, but you still document that they got the pamphlet, because they did maybe at another visit. Good? Huh? You gotta raise your voice, Stan, I can't see. Every time you have to offer it to them, but if they say you already gave me that and they don't want it, you don't have to give it.
So the rules regarding this, I just had a conversation with our risk manager, who was a risk manager for the state, and the rules for this law have not been written yet. Okay? So it's not determined yet whether you need to give this every time or whether it's just once. I can tell you what we do in our practice is not only do we give it to them when they come in, but we have them sign a document that says they got it. And we keep all that in the record. Yeah. To prove that they got it.
It's ludicrous to keep giving it to them.
Right.
Yeah.
But the regulations, your law passes, and then the regulations have to be written. And quite frankly, the regulations haven't been written yet. It just goes to the Board of Pharmacy, the Board of Medicine, coming up in their meeting in August.
I did 35 minutes. She's got an hour, and now she's got an hour.
Guys, I just see a number of people taking photos with their phones. You don't need to do that. Right now, the lectures are not on the app, and Michelle is aware, and we're putting them on the app. So you'll be able to get all the lectures. You'll download the lectures. You'll be able to see it. Or you can go to the website and call up this meeting. So every slide that's there, you have access to.
You had a question, ma'am? You had a question? You have to write a letter to the Department of Health saying that you're a board-certified, fellowship-trained pain management physician, and you are considered exempt from the law, and can they please respond? And if you want a template for that, I can get it to you.
Can I follow up on that for a sec? There's actually a form from the Department of Health that you have to fill out, and you check which exemption you have, and then you have to provide them documentation that that's true, that you are board certified,
your board certified
fellowship trained,
certificate,
that you are part of a multi-specialty group. Whatever the exemption is, and there's I think 5 or 6 different exemptions, you have to show documentation, show proof to the state as you send that form back. Department of Health.
Department of Health website.
It's a one-time thing, but if your status changes, say you go from a single person-owned group to a multi-specialty group, well, guess what? You have to change that through the state.
Okay, yes. If the law changes, no, but if the law changes, you would, or if the Board of Medicine rolls out something stating that you're going to do this every 2, 3, 4 years. They haven't done that yet, so right now we don't know. Yes? What was that? You had a question? No? Okay. Any other questions? Okay. Yes?
The exemption, just brought up here, you're exempting and you prove it. Is there a time limit?
We don't know yet. We get the exemption certificate and the Board of Medicine will roll out. For right now, we think it's, infinity, but we don't know.
Until it changes.
So I was previously registered, and then I meet the requirements for not being registered, so I'm like, okay, I don't want to be registered.
Okay, so maybe communication. See, you made a change from being a pain clinic to not being a pain clinic. So you're in a different category than the rest of us who are just,
Well, but that's weird because she proves it. She gets deregistered and then she proves that she has the exemption by proving that she has the training. Then they want to see it again and again.
well, you know, it's kind of fuzzy, gray, but Jesse is not a pain clinic, and he registered just to, the big group, SciMed, 200-something doctors, and they did it just to cover their gluteus maximus.